So thank you for having me present on airborne transmission of SARS-CoV-2 and talking about what some of the evidence is to support the fact that we think this may be getting around a little bit more than other kinds of droplet infections through the airborne route. So in infection prevention, this chain of infection is vital to how we work. So when we have an infectious agent, whatever bacteria, virus, fungus, mold, whatever we're dealing with, we then think about where is the reservoir? Where could this be hanging out? The portals of exit, how does it get out of the body and transmit through modes of transmission to get to other people? And portals of entry, how would it get into that person's body? And what are our susceptible hosts? Especially with SARS-CoV-2, we're seeing that patients who have diabetes, who are obese, have cardiac disease and lung issues, autoimmune disorders or cancer, are more susceptible hosts. So that's how we're able to work in outbreak investigations and then institute what we call control measures. So the modes of transmissions of infections are direct contact with infected secretions, excretions, blood and body fluid. So with COVID-19, we do know that most of the direct contact would be with infected secretions coming from the nasopharynx and the lungs. But we also know there can be GI conditions with this. And so therefore we would have to worry about feces as well. An example of a complete direct contact disease would be bloodborne pathogens, where you have very direct contact with somebody who's got HIV, hepatitis B, or hepatitis C. Indirect contact is that it gets contaminated into patient items in the environment, and you come in contact with those indirectly. A stethoscope, a blood pressure cuff, a bed rail, a bedside curtain. We typically see this a lot with environmental organisms like MRSA or meth-resistant Staph aureus, also vancomycin-resistant Enterococcus, and carbapenem-resistant Enterobacteriaceae, as well as C. difficile. But we do know, and studies have been done, that COVID can contaminate surfaces. So the scenario here would be that you touch a bed rail after suctioning a patient, and for whatever reason you didn't have gloves on, or you took those gloves and you had an itchy eye or your nose and you cross-contaminated from an indirect contact into your nasopharynx. We also have what's called droplet nuclei transmission. So this is typically where we see influenza, coronaviruses. There are 7 different strains of coronavirus. So it's interesting, there are 4 of them that cause a common cold. And then there's SARS-CoV-1 that lasted about 2 years back in the early 2000s. And then we start to see MERS-CoV, which is Middle Eastern Respiratory Syndrome. We also have pertussis, bacterial meningitis, but we also have, we're thinking that most of the spread of SARS-CoV is through droplet. And what droplets are is when you cough or you sneeze, it's kind of like the shower of secretions that come out, and by gravity, most of them will pull down 3 feet once you push them out of your system and down to the earth. But others become micro aerosols, as we'll talk about, and can suspend in time and almost appear and be like what we call airborne route. So typically airborne routes of transmission are tuberculosis, chickenpox, measles. They have very small microns. They can suspend and travel in the air for a good period of time. And so these tiny small aerosols we're seeing with SARS-CoV-2 as well. We actually tend to see it more, which is, I think the epidemiology shows us, in asymptomatic or early onset infection, and not so much in late onset when they're in the intensive care unit. And one of the ways that we kind of have a sense of that is that we're not seeing major hospital outbreaks of SARS-CoV hospital-acquired infections. So all of the PPE that they're wearing, increasing the negative pressure in the rooms, is helping to be able to disperse these small aerosols and not cause transmission. But when you get a bunch of people in a bar, a very closed space of a theater, and so forth, that's where we can have more of these aerosols moving around and causing an airborne route where you would inhale it. And then there are some conditions that are what are called vector-borne, West Nile virus, equine encephalitis, malaria, Ebola. So what happens with somebody who gets COVID is the person's infectious 48 hours before the symptom onset. And then hospitalization may be later in the stages of disease. It's not uncommon for them to stay at home like the flu and ride the wave through those high spiking fevers and difficulty breathing. But unfortunately, some of them wait a little bit too long because of the way this virus affects the platelets and the red blood cells and the lungs and can move throughout the entire system. And then by the time they get to the hospital, many of them have to have extra oxygen and be put on ventilators. So as I said, it's interesting that there's no hospital outbreaks of COVID. And even though they weren't following what we call airborne precautions. So that's good in the sense that most of it seems to be droplet and can be contained with the use of PPE, especially the masks and the N95 respirators. Initially, there's direct damage to the tissues, and then there's this very massive immunologic response and parainfectious syndrome that requires them to get hospitalized. And by the time that they're there in the hospital, their infectiousness has likely decreased. So again, it's more transmissible in those early stages. It is now clearly recognized that viral RNA, you'll see many of these studies look for viral RNA for the testing, but that doesn't equal risk of transmission. So when we look at, like opening up school systems or opening up places where we typically have a crowd, like we said, a bar, or malls, or theaters, you have to look at how big is the space. You have to look at what kind of airflow they have. Are they breathing the same air, or is there an very good flow, or windows are open and exchanging the air? So indoors, the more air exchanges, the less likelihood of spread. And many hospitals have increased the number of air exchanges, or have they brought in negative pressure isolation machines. We'll see that quite a bit. There's a couple of very good innovative ones. One in particular has a HEPA filter with a UV light, so it will just suck in all that air and actually sterilize it. So we call this transmission SPAT, or small particle aerosol transmission, where these viruses can remain in aerosols and then spread and travel distances of 1 to 2 meters or 3 to 6 feet. The viruses get released when you're exhaling, you're talking and coughing, and they become these micro droplets small enough to remain aloft in the air and pose a risk of exposure at distances of about 1 to 2 meters from an infected individual. So the viral RNA associated with droplets is smaller than 5 microns, and it's been detected in the air. And it's interesting, our nasal passage is able to filter out with the hair that we have in the anterior nares and the mucus and the immune system that can trap these organisms. The key thing is that these little microns, if they're so small, they transfer up through the nasopharynx, and that's where they start to replicate. And so that's why we have to put them on classic airborne transmission precautions, where we would have them in a negative pressure isolation room, N95s for everybody going in and out. And that's created some of the challenges, as I mentioned, in the hospitals, and trying to convert the air into more of a negative pressure. In the ICUs, the air is positive. We typically have to have one room set aside negative pressure for if they're doing bronchoscopies, and especially with somebody with TB. But that's been the biggest challenge in the hospitals, is to create a negative pressure room situation. So that term of airborne implies a common set of one-size-fits-all interventions to prevent transmission. It requires that intensive engineering controls that I just mentioned and very specific PPE requirements. So this is what's not really clear of whether we classify this as airborne, or, as most evidence suggests, it's much more a droplet type of a transmission. But as we know, in certain situations, as we mentioned earlier, with very closed airspace, these small aerosols can cause more of an airborne transmission. So what happened on July 6th, about more than 230 experts in infectious disease signed an open letter to the WHO recommending that it is time to recognize evidence that the coronavirus is airborne. And this letter argues that public health institutions must update their recommendations to help avoid those risks. What happened is the WHO on July 9th did say that this could be airborne indoors. So these airborne transmission, all along they were saying, let's focus on aerosol generating procedures, suctioning, nebulizer treatments, bronchoscopies, procedures that we know are going to generate a lot of aerosols. But now they're recognizing that in indoor settings with poor ventilation, we have to start to think about controlling this by putting in some of these engineering controls to prevent these clusters and outbreaks. And most of the epidemiology supports that clusters and outbreaks have been associated with bars and churches, homes and schools and restaurants, manufacturing plants, places where a lot of people together with no protection of the nasopharynx that are then breathing in one another's airs. So the WHO goes on to say outside medical facilities, that these reports, that have been to the indoor crowded space situation, could be where we have aerosol transmission. And this is a very short range aerosol transmission through these droplets. We also know that the investigations have shown that it's not just droplet and possibly some aerosol movement, but the fomites. And so fomites are that environmental sources of pieces of equipment that then can be used from one patient to another in a home situation. You can imagine bathrooms that are getting shared, kitchens, tables and utensils and so forth, that can then possibly transmit it through what we call fomites. So the theory suggests that a number of respiratory droplets generate these microscopic aerosols that are less than 5 microns. Normal breathing and talking can result in exhaled aerosols. So that's important when we start talking about asymptomatic or early onset people with disease. And so these susceptible people could inhale the aerosols. And these aerosols can be in a sufficient quantity to cause infections. However, the proportion of exhaled droplet nuclei that evaporate and generate these aerosols and have an infectious dose to cause these are not known. So that's the thing that's just, you can imagine, we're just really 5 months into this outbreak if it started kind of mid-March. And so that's the key, that every day, all I do is just read journals and, look at the news to see what's the latest research that has come out so we can actually learn more about this virus. Now, there have been environmental studies that have been done that have generated aerosols of infectious samples that were powered by jet nebulizers under controlled laboratory conditions. And they found that with this particular virus, it can suspend for up to 3 hours. One study found 16 hours of viable, competent virus in the air. And so that's the key thing about the healthcare setting. We have found that these aerosol generating procedures, when they're not performed, were not performed in some situations, and yet they still found the RNA in air samples. But as I mentioned earlier, what we're not sure about is, does RNA equal transmission? Because they have not found the viable virus in the air samples. So that's where it becomes very confusing when you read the studies. You have to say, well, that was RNA. That was not actually the virus itself. So the WHO did change their stance and came out with these recommendations to provide sufficient and effective ventilation, supply clean outdoor air, and minimize recirculating air, particularly in public buildings, workplaces, environment, schools, hospitals, and aged care homes. Supplement the general air ventilation with airborne infection control, such as exhaust systems, high efficiency air filtration, as I mentioned earlier, and germicidal ultraviolet lights, and avoid overcrowding. So that then puts into place the support, some of the control measures of keeping certain sectors of society shut down, like the bars at the moment, in a lot of the states that are having, or in the countries that are having increased spread at the moment. So we came up, a friend of mine, Peter Graves, who's a nurse from Texas, we were actually developing a website, a pandemic website. I actually have a 7S bundle for surgical site infections and a website, 7sbundle.com. And we're setting up right now a pandemic bundle and looking at 7 steps to a foundation in a plan. So you want to make sure that you have a very detailed description of how you're doing screening and how you're doing data analysis. Antigen means you have the virus in your body when it's positive. Antibody means you've already had the infection. Unfortunately, this antibody protection wanes in about 2 months. So that's what we're not sure of, whether we're not going to really have a good antibody response or herd immunity, where a lot of people get this and then have protection against it, because there have been patients who had antibody, already had it, and gotten a reinfection. So safe environment, looking at disinfectants, and what they do is they clean the environment, but unfortunately right after that it gets recontaminated. And maybe in some situations like what we're talking about outside the hospital situation, what about long-acting antimicrobial solutions? There are some that can last on surfaces for months and have pretty good data to support that. Ultraviolet lights, there are robots. They even have small UV boxes that you can put stethoscopes and pens and cell phones and iPads and zap those within, one of them is only 30 seconds, and you can sterilize that piece of equipment. Hydrogen peroxide for surface disinfection. They're now dry hydrogen peroxide, vaporized hydrogen peroxide, and binary ionization technology. Dry hydrogen peroxide, there is a product that was developed by an Army engineer during the anthrax outbreak. And it goes into the ventilation system, or it gets mounted in a room, and it puts out this dry hydrogen peroxide, non-toxic to humans. And it is able to kill not only coronavirus, tuberculosis, it can kill mold and mildew, even vermin like bed bugs, and take odors away. So we've got really unique technology coming on the market now. Air purification and disinfection devices. There are devices that do use hydrogen peroxide. Could come in and just, fog your room. That HEPA filter unit I talked about, the portable unit, and UV lighting. Then there's supplies to protect healthcare workers. One of the ones I have at the top of the list, and I've been recommending this constantly, is a nasal antiseptic with alcohol and citric. And it's a long-acting antiseptic. So wouldn't that be great to have right at your nasal passage a product that can kill the virus as it comes in? Rather than maybe in the school systems, this might be the option rather than wear masks. For poor kids that would have masks on have to have mask breaks. And then there are all kinds of masks, but the filtering face piece respirators are by far the best to prevent these small aerosol microns from coming in. We also have face shields and gowns and gloves, footwear, and engineering controls. You probably see a lot in public now, plastic shields and barriers, and the social distancing of tables and chairs and counters. Sanitizer and soap, really don't need to say much about that. There are some antimicrobial long-acting with soaps that give you a residual buildup. And then you also have to make sure you have lotions available that are compatible with your soaps, so they don't deactivate the product. So there's a lot that comes in around this whole topic of hand hygiene. And then there's scrubs and linens and textiles. There are even antimicrobial linens and sheets and cubicle curtains. And then systematic instruction and education. Many online courses and training now, webinars, and assisted learning systems that you can use to continuously educate your staff. The last one is skin and personal hygiene. It talked about those UV boxes, the nasal antiseptic, homemade masks need at least 2 layers. The antimicrobial masks, there are some that have silver, copper, and a long-acting antimicrobial solution. And there are antimicrobial soaps and sanitizers over the counter, and instructions for how to make your own from the FDA. So here's some references, and I'm available if anybody wants to get in touch with me at maureenSpencer@gmail.com. And I want to thank you for having me do this presentation on air contamination and COVID.